Hi, this is Brian Kim. I'm going to share with you case number 96 in the best way to do cataract surgery series. This is a dense cataract with loose zonules, and I'm going to do double chop, cross chop, and mechanical fracturing in order to reduce ultrasonic energy and systematically disassemble this lens quite carefully here. I'm also using the hybrid tip, which has this polymer material, and I've been test driving this polymer tip as well. It's not as effective as far as being able to hold the lens with my chopping technique. However, it still works quite well, and you'll see me using that tip on this case. So I'm using a corneal marker, which will help me to center and size my rexus. I'm using a metal blade in this case to make my paracentesis incision. I want to make sure that the incision is parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see this pupil is really nice and widely dilated. I'm going to inject some intracameral lidocaine and then some dispersive viscoelastic to fill the chamber. Use a cannula to hold the eye. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove. You can see this patient's eye is moving, and so that's why the cannula is so nice here. I tunnel through the cornea, and then when I'm ready, I enter. I push some more viscoelastic. This patient's moving a little bit. I'm probably telling her to just try to relax and keep the eye nice and still. So this is the puncture style capsular rexus. I go in with the teeth sideways, puncture the central anterior capsule, pull it downward towards me, grabbing the right side of the tear to create a flap, going around circumferentially, grabbing and re-grabbing, trying to follow the corneal mark that I made, which will hopefully allow me to get a nice, well-centered and sized rexus. I go ahead and finish off the rexus, burp some viscoelastic out. And this is the capsular fornix hydrodissection technique. I place a cannula underneath the rexus edge contra-incisionally, point the tip down, get a nice wave, turn the tip back up, decompress on the left side, turning the tip on the right side down, and I start to spin the lens here. This, in my experience, is a very effective and easy way to perform hydrodissection. Go ahead and irrigate the surface of the eye, and rotating the sleeve, you can see the white end of the polymer tip. Lift the incision with a chopper, go in with irrigation off to minimize decimase trauma, removing the surface epinuclear material, placing the chopper underneath the rexus edge contra-incisionally, pointing the phaco tip vertically sub-incisionally, bringing both instruments together and fracturing the lens in half. That's double chop, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, which is acting as a fulcrum, and then it crushes the right heminucleus in half. That is the cross chop. Using some vacuum to lift that first quadrant up, getting the chopper around the lens piece, crushing it in half and creating smaller pieces out of that first quadrant, and then emulsifying the lens pieces. Placing the chopper around the second quadrant, pulling it centrally towards the phaco tip, and then bisecting that piece, and then using successive mechanical forces to crush the lens pieces into smaller pieces, and then emulsifying the lens pieces. Using the chopper to turn the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, which is deep in the bag. The phaco tip acts as a fulcrum so that it allows the chopper to crush the lens in half. Placing the chopper around the fourth quadrant, doing the same maneuver, and then crushing the lens as well again. I use the analogy of the chopper being like a knife and the phaco tip being like a cutting board. And so it allows that opposing force when I'm trying to cut the lens. So I turn the fourth quadrant around me, using vacuum to hold it, and then getting the chopper around it, crushing the lens and bisecting the lens, and then crushing it again and again into smaller pieces, and then emulsifying the lens pieces. I did feel like the emulsification efficiency was a little bit less than with the metal phaco-tip, but nonetheless, if it provides more safety and it reduces the risk of posterior capsule rupture, then I think it's a great thing. So once the endonucleus is removed, I remove the epinucleus, which tumbles out quite nicely. Do the same thing with the epinuclear material subincisionally here. So I'm done with that. I go ahead and take the chopper out, push BSS in, take the phaco-tip out, and go in with the INA handpiece. I start subincisionally removing the cortical material from anterior to posterior. Using foot pedal control, trying to be able to make sure I remove the cortex from anterior posterior the way I want to. But in some cases like this, you don't really have a choice and it just kind of tumbles out. You end up with this fine cortical material that's still left. So I'm carefully teasing that material off because there's quite a bit of it left in the capsular fornix as well as the anterior capsule rim, going around subincisionally as well. Switching to polish mode and polishing the lens epithelial cells under the rexus edge, polishing the posterior capsule in the subincisional space as well. You'd be surprised if you don't polish in that area, you can end up having quite a bit of lens material there. So I'm using the cannula to pulse the subincisional space, and lo and behold, you see some material start coming out. Push some cohesive viscoelastic to fill the capsular bag. And then I'm going to use a sweep to polish under the rexus edge. You can tell this is a big eye with a somewhat soft sclera. And I'm using a 3-piece lens, so I'm going to have to use the blade to widen the incision. Turn the barrel bevel towards the left, deliver the leading haptic into the bag. As the optic is delivered, I rotate my hand counterclockwise a little bit so that the optic comes out flat. I use the Maltzman to dial the trailing haptic into the bag. So I go in with irrigation off, activate irrigation, go underneath the lens, removing the viscoelastic from within the bag. Removing the viscoelastic from the subincisional area, removing the viscoelastic from the anterior chamber as well, and I'll hydrate my incision. So this is a fairly dense cataract. I'm using the hybrid tip to perform double chop, cross chop mechanical fracturing techniques. Again, the CDE is kept minimum because I'm able to use crushing forces. Again, I'm using the chopper like a blade and using the phaco-tip almost like a cutting board, and I'm able to disassemble the lens in a very controlled and systematic manner. And I'm able to keep the CDE quite low, which allows me to achieve really very clear corneas even day one after surgery in these dense lenses. So I hope this was helpful to you, and I thank you for your attention.